Hi, everyone, and welcome to today's IPE case study presentation. Before we get started, I just wanted to go ahead and introduce the investigative team. I'm Stephanie Katz, an MPH candidate who's specializing in health promotion and behavior science. I currently work for a primary care delivery company doing the health promotion strategy. And I've been working with Dr. Suzanne Adams, who's a clinical psychologist with over 15 years experience in mental health and public health fields. And we partnered particularly for this study because of her experience in treating substance use disorders and recovery in her patients. Okay, so before we actually got started, the two of us actually established a statement of approach. That meant that we would acknowledge and respect each other's knowledge and areas of expertise. We would have shared goals and approaches. And in this case, it was using the social ecological model to assess and address healthcare needs and identify additional opportunities to advance the health of the case study patient and family. So using that as our guiding principle, we kind of delved into the case study, and it was very clear from the get-go that using that statement of approach as well as a patient-centered approach, there were some things that we needed to consider immediately. Dr. Adams brought her expertise and pointed out that we needed to actually think about this patient's medical history and whether there were risk factors for mental health and substance abuse problems. It was clear there were competing priorities between the individual and their family, namely establishing financial security in the workplace. There were clear pain management concerns as well as mental health concerns that evolved over time for both the patient and the family. There's always a stigma of opioid addiction. In this case, that stigma could have existed within the family, within the workplace, or within society. And then there was a concern of additional workplace safety hazards, as well as a benefits policy that could be adding stress or actually removing stress from the patient situation. So delving further into the case study and using that as our guideposts, we identified a number of missed opportunities. The first was that from a clinical perspective, the provider didn't actually assess risk before prescribing opiates. And then actually when deciding to prescribe opiates, the prescriber didn't develop a pain management plan or help educate the patient about goals and risks that they should be aware of when taking opioids. All of this are recommendations from the national guidelines. And just to be clear, this was something that neither the initiating primary care provider, subsequent primary care providers, nor emergency medicine professionals actually utilized. All right, the next missed opportunity was that when there was a dosage increase and the patient returned and the doctor doubled their dose, there was no risk-benefit analysis, which is a national recommendation that clinicians should make before increasing dosage. And in addition to this, regardless of how that risk-benefit analysis turns out, whether the risks outweigh benefits or vice versa, there's also national guidelines around the fact that providers should be optimizing for non-opioid therapies. So in this case, the patient had 3 months of PT after their traumatic injury and surgery, but at the point of increasing dosage, there was no investigation or exploration of non-opioid based therapies. Furthermore, none of the clinical providers nor any of the pharmacists involved consulted the state prescription drug monitoring data. This is a database that aggregates all of the data around controlled substance uses for individuals. And in California, there's the CARES database. And so there was no mention of this by any professionals. And if consulted, that would have been a good opportunity to flag this patient's use. Further, when the PCP finally became concerned and actually discontinued the prescription of opioids, this was actually contrary to national guidelines, which calls for a taper to lower dosages. And that's because abruptly discontinuing opioid prescription can lead to withdrawal, exacerbation of symptoms, both psychological and pain, and then patients actually looking for opioids from other sources, which is exactly what happened here. And so there was no reports of the clinical providers tapering in this case, and it was sudden abandonment, which actually is contrary to this idea that clinicians should be responsible for coordinating and continuing care. In addition to that, there was no shared treatment plan with the family or no family involvement. Social support, we know, can be a powerful construct that influences health outcomes. More specifically, there's research that shows that when there's a shared family treatment plan, negative outcomes like relationship stress are actually attenuated. And so in this case, neither the patient's wife nor any of the clinicians actually look to work together to have a shared approach. And finally, the workplace was a primary character in this case study. And this is a workplace that's in the construction industry, which has been increasingly linked to high rates and high numbers of opioid use and overdoses. And there was no strategic approach by this workplace to prevent, intervene, create treatment or recovery policy for its employers. And so there needs to be a better effort there, which we will address in the recommendations. All right. So before we actually sat down and kind of prioritized and documented recommendations, there was a lot of research that took place. There was a peer-reviewed literature review through PubMed using Boolean search operators, which are listed here on this slide. We also consulted national guidelines, including the CDC, the HHS, and CMS. And then Dr. Adams brought her own knowledge of prevention, treatment, recovery, and maintenance to the equation while we worked through the case study. So there were 4 chief recommendations that we made based on the missed opportunities. The first one was around medication-assisted treatment, which would affect the patient at the individual level and demand partnerships from referring primary care providers, medicine from pharmacists, and then also intervention from behavioral health specialists. And medication-assisted treatment is basically a combination of FDA-approved medication like buprenorphine, for example, as well as behavioral counseling. And this has been actually proven more effective than medication on its own or counseling on its own in decreasing opioid use and increasing social function and retention in treatment. And this is particularly, I think, valid for this patient's case because MAT has been proven to reduce the need for inpatient detoxification services, which means the patient can continue working and functioning in their life without having to be within a facility. So the recommendation here would be for the patient to actually start a MAT program rather than the hospital-based program that the primary care provider recommended. In addition to this, we actually want to get the patient's family involved, and there is an intervention called CRAFT, which affects the interpersonal level of the SEM and demands partnerships from referring primary care providers, behavioral health specialists, and also the patient's wife in this case, or whoever that social support structure is. But basically, this is an intervention that says that pairing that psychosocial therapy portion of MAT with the patient's significant other or social support structure will have better outcomes than just having the patient go through that psychosocial therapy on their own. Specifically, this calls for individual therapy for the patient, paired sessions with the significant other, and then individual therapy with the significant other. And this has positive significant effects on patient opioid use, according to research by Brigham. And so the patient's wife can participate in this kind of support. Additionally, there needs to be enhanced provider education, which affects the organizational level. There's lots of continuing education that national organizations have developed in response to the opioid epidemic. And these programs cover everything from opioid prescription to pain management to prescription drug abuse to challenging patient situations. And federal agencies need to continue to work to expand these programs, understand which are most effective and how to deliver them effectively to clinicians. But in the meantime, they exist, and all of the clinicians involved should actually educate themselves further. And also the HMO administration involved, who has these providers and network, should be promoting these kinds of programs to their providers. And so the partnerships needed would be PCP, the HMO, and then other clinicians like emergency medicine professionals. Last but not least, there needs to be quite a bit of work done by the workplace itself. Again, this is at the organizational level. There's a total worker health framework, which has been developed by the NIOSH. And this calls for policies, programs, and practices around worker safety, mitigating health hazards, but also promoting prevention and injury prevention, illness and injury prevention efforts. And so when it comes to opioid use, as this has been identified as something more and more linked to the construction industry, employers within this field need to have a solid framework that approaches this from a preventative intervention, treatment, and recovery standpoint. And all those things could impact patient help-seeking behavior. It could reduce stigma of seeking help. It could also allow for a safer, more supported return to work where pain can be better management, as well as benefits policy that prioritizes non-opioid treatment options. Okay, so there was quite a few lessons learned from this, including I think developing a shared objectives at the beginning was really successful for us and kept us focused. Also, I approached a few other specialists in the beginning, and then after reading the case study, they decided that it wasn't something that they could speak to comfortably. And so it really taught me about understanding roles and responsibilities before partnering and collaborating. And then last but not least, Dr. Adams and I have had an established relationship and friendship. And so there's quite a bit of trust and respect. And the way that we were able to communicate and work through areas of conflict was facilitated by that. So those were all core competencies in the IPE, and it made this project and investigation really interesting and seamless. Okay, thank you very much. And here are some references used.